Thank you once again for being with us. My name is Chichi Undie, and I'm a Senior Associate and Technical Director with Population Council and also the Council's regional representative in Kenya. I hope you can all hear me. Mic seems to be going in and out. I should mention that I've also served as a co-chair on the Center for Humanitarian Health, Lancet Commission on Health, Conflict, and Forced Displacement. And it really is an immense privilege to finally be able to launch this report in Nairobi, Kenya, which, as we all know, is an important regional hub for humanitarian response. And for the benefit of anyone who may not be familiar with what a Lancet Commission is, it's a multidisciplinary group of experts assembled by the very well-known medical journal, The Lancet, to investigate critical changes in health and development. So Lancet commissions tackle the most pressing, complex issues in science, medicine, and global health. The multidisciplinary panels of experts who compose these commissions, they evaluate existing evidence, they provide critical framing, and then they publish actionable recommendations that influence policy, drive political change, and improve global healthcare practices. Paul Spiegel with the Johns Hopkins University Center for Humanitarian Health happens to be the chair of this particular commission that brings us together today. Now, this launch in Nairobi is one of several that are taking place around the world, from Geneva to Washington to DC, to Dakar, to Amman, Dhaka, and Bogota. These launch events are contributing to marking the beginning of a global series of conversations, bringing together policymakers, practitioners, researchers, and affected communities. I would like to acknowledge that we have an online audience as well, and I hope that they can hear us. Thank you very much for joining us despite the constraints. For various logistical reasons, we are asking that our online guests take note of any questions that they may have and that they will email them to us, which is an approach that has worked well in some of our launches. And we'll be sure to get back. The email address is info@healthconflictcommission.org. Info@healthconflictcommission, that's one word. Info@healthconflictcommission.org. We'll be sure to get back with a response. We apologize that the short amount of time won't allow us to interact more. And may I ask that if you are a speaker today, meaning you're either giving a keynote speech or you're one of our panelists, if you wouldn't mind making your way to the front of the room, we have some seats reserved here. Before we get into the presentation, I would like to walk us a little bit through the agenda. On your seat, you'll see a number of materials. You'll see the executive summary of the Lancet report that we're here to share today. Inside that packet should be a copy of the agenda. You'll see that it's short and to the point. This is essentially a 2-hour agenda in this room, followed by maybe a half hour more in the very next room, where we're going to end with cocktails and networking and so on and so forth. So it's quite a simple agenda where I'll be taking us through a presentation of the report. This will be followed by a keynote speech, and then by a panel of humanitarian experts to kind of delve a bit more into certain aspects of the report. And then we'll have a Q&A where we can, share our comments and questions and do our best to respond. So the title that we've given to this commission is Health in a World of Crises and Impunity. And I would like to emphasize that this title was intentionally bestowed and that it highlights two things in one breath. First of all, it highlights the crisis itself, and then secondly, it highlights the failure to enforce the protections we already have. Health in a World of Crisis and Impunity basically is not a neutral title, rather it's a problem that we must face. I know that we're all humanitarian stakeholders here, and this information will be familiar, but we thought we would put what we all have a sense of into clear figures up here on the screen. So between 2021 and 2024, we may know that conflict-related deaths nearly doubled. In 2026, 239 million people need humanitarian help. Only 87 million, that's about 36%, are actually prioritized. And this is really rationing by design. 23 billion US dollars would cover the world's most threatening or life-threatening humanitarian needs. And that is actually less than 1% of global military spending. So the money is there, and what is missing is the political will. The system that was meant to respond has been gutted. And this has happened at exactly the moment where the need is greatest. I'd like us to look at the portrait of forcibly displaced persons over the last 4 decades or more. And what we see is that in 1980, forced displacement was a small phenomenon. And today, more than 123 million people are forcibly displaced, and this is the highest number ever reported. If you look at the line after 2011, so Syria, Yemen, South Sudan, Tigray, Ukraine, Sudan, Gaza, each rise is a political failure that ended up becoming someone's permanent reality. As we know, displacement now lasts decades, and a system that was built for short emergencies is being asked to manage what are essentially life sentences for many people. Globally, there are reported attacks on healthcare. In recent years, we're seeing attacks on health workers. We're seeing attacks on hospitals and clinics. We see attacks on supply chains and patient transport. And this is all rising very quickly and relentlessly. In 2024 alone, Insecurity Insight reported 3,663 attacks. That is 18% more than 2023, and that's also 58% more than 2022. Now, these are the attacks that we happen to know about. The real number is, certainly higher. In Sudan, 70% of the health system was destroyed in the first 6 months of the war that began in April 2023. In Gaza, hospitals were systematically targeted. We see the same pattern in Ukraine, in Myanmar, and elsewhere. But attacking hospitals is not a tactic of war. It's against the law. Condemnation without consequences is sadly the norm, and it's unacceptable. And to answer the question of who actually controls the response, here's a picture provided by this slide. So the grand bargain promised that 25% of humanitarian funding would go to local actors by the year 2020. But nearly a year later, we're still far from that target. In 2024, 95.7% of direct humanitarian funding went first to international actors. Only 4.3% went directly to local and national actors. So this is not a technical failure. Rather, it's a failure of how power, trust, and resources are shared. And here's another picture, this time one that presents equity across the past 15 years. So between 2009 and 2024, the 10 largest humanitarian crises produced 55 to 75% of the world's internally displaced persons and 64 to 84% of all refugees. Yet those same crises received only 29 to 54% of humanitarian funding. And this gap has remained pretty stable across 15 years. However, in some years, it's more than 40 percentage points. The point, though, is that this is not anecdotal, this is structural. I'd also like to point out that behind every statistic that we present on these slides is a person. And this commission has worked hard to listen to them. These images come from a photo voice study. Hopefully you can see them. A photo voice study conducted as part of this commission with displaced Syrian youth in Turkey. So at the top, what is my top, I guess you would call it my top right, or you might be the top left, the very first picture. It really depicts 12 years after displacement, how a young person is still living in the shadow of an earthquake. And in the middle, we see a picture of isolation in a school where the student concerned had lost family and had no one. And then at the bottom, it's a pot of food brought by a Turkish neighbor when her mother was sick. And so we could say that that is solidarity captured in a single object. One of the things we really wanted to do with this commission was to ensure that the voices of people that the humanitarian system serves shapes not only the diagnosis, but also the recommendations. And the case study from Turkey was one way of doing that. So just to delve a bit more into the commission process, our work took place over a 2-year period. It took over 2 years, actually. And it was a huge undertaking involving 21 commissioners and 21 next generation scholars from all over the world. Some of them are here with us in this room today. The group was extremely diverse, deliberately so. Many of those in the group actually had lived experience of conflict and displacement. That was deliberate. We also had an advisory committee made up of 29 experts, so donors, UN agencies, other multilateral organizations, and NGOs. Importantly, the commission was also shaped by 533 affected people and humanitarian workers interviewed across 12 countries, including several on this continent. And then the analysis was strengthened by 13 thematic working groups and multidisciplinary expert reviews. So this has been an ambitious project, and the ambition really has been structural in nature. The whole point has been to rethink the strategies, rethink the governance, and to rethink the delivery of humanitarian health, and to amplify the voices of those that the system serves. We realized early on that before we can truly focus on health and saving lives, the humanitarian system needed to be fundamentally transformed. So we want to emphasize that this is not yet another call to do better. Rather, it's a call to do differently and to do so now. And so to organize our analysis, we developed a conceptual framework, and I'll take us through it a bit rapidly in around 3 steps. So first of all, the heart of the framework is the individual, is the person, rather than the agency. And so we anchor the response in the people themselves, right? Individual, household, community, service providers, and then recognize them de facto authorities. We then move to the humanitarian development and ecological environment. So these are not separate worlds. And then on the left are the drivers of the crisis, conflict and insecurity, forced displacement, public health emergencies, and all that you can see on the rest of that part of the slide, climate-induced events, other drivers of conflict and violence, and then we put them into 3 crisis typologies. Acute, on protracted, and then protracted. And each needs a different response. All of this affects the health of people, and that's what we refer to as, quote unquote, humanitarian health. So the strategic drivers, which you see across the top, they sit across all of this. There's international law, humanitarian principles, governance, financing, and health systems, and these are the levers essentially. And every recommendation made in the commission report draws on one or more of them. And then finally, 6 themes run across everything we propose. So you see them like running across the bottom. There's social determinants of health, populations in conditions of vulnerability, community engagement and accountability to affected populations, data and evidence, technology, including AI, and localization. And I should point out that these were not chapters in the report, rather they are, threads running through every recommendation that follows. So speaking of recommendations, let's start with them. Our first recommendation is to invert the power. Affected communities and local actors, they are closest to the need. They act the fastest. They are most accountable to the people that they serve, and yet they remain at the edges of decisions about their own crises. And a health official in DRC told us decisions are often made in the capital or internationally, far from local realities, which leads to delays. So this is not a flaw at the edges. This is really the system as it has been designed. And success is that it can't be measured by whether communities were consulted. It has to be measured by whether they controlled priorities, resources, and accountability. Here are some examples of key actions. First, apply a crisis typology and decision matrix. And this is because different crises need different responses. An acute emergency can't be managed in the same way as a 20-year-old conflict. And a protracted crisis shouldn't be treated as a permanent emergency. Second, make subsidiarity the default. So decisions should be made as close as possible to the people affected by those who are legitimate, capable, and trusted locally. So the question should shift from which international agency leads to who closest to the crisis is best placed to lead. International leadership should be the exception. It should be time limited, and it should be linked to clear handover benchmarks. And safeguards have to ensure power shifts to communities and not simply to local elites. Third, simplify the architecture. The system as it's set up today, it's too fragmented, it's too competitive, it's too slow. There are too many agencies competing for the same mandates, the same resources, visibility, whether they be international NGOs, UN agencies, or whatnot. And so we recommend creating a leaner, integrated, and accountable operational UN entity. We also recommend replacing the cluster system and the refugee coordination model with a fit-for-purpose incident management system, particularly in acute settings. And so, as catchy as it sounds, invert the power is not a slogan. It has to become the operating default so that decisions, resources, and accountability move closer to affected people. Now, with the decision matrix, subsidiarity becomes a practical tool. This is the matrix that asks 4 sequential questions. First of all, what do communities define as their priorities and who do they trust? Second, who has the authority, legitimacy, and ability to protect people? Third, who is already delivering care? Local NGOs, faith-based providers, private providers, informal systems, or national institutions, and where are the gaps? Only then should international actors enter, and only to fill a clearly demonstrated time-limited gap with handover benchmarks from day one. And then fourth, can the health system hold, adapt, and recover over time? So external leadership should be the exception, not the norm. And it must always be time-bound. We always have to have a clock on. Recommendation 2 is end impunity. The enforcement of international law is selective at best. Accountability is absent, and civilians and health workers pay the price. In Burkina Faso, a health official here described the impossible position that some medical workers face, saying, "If I treat a member of an armed group responsible for killing my brothers, it tests my patriotism. If the government finds out, I could face repercussions. Yet if I report it, I risk being seen as an enemy by the armed groups, which could endanger my life." The laws already exist. International humanitarian law, international refugee law, human rights law. They are designed to protect civilians, patients, and health workers. In today's geopolitical climate, this is not the moment to revisit these laws. The core problem is non-compliance and without consequences. Security Council Resolution 2286, passed in 2016, was meant to protect healthcare in conflict. Now, a decade later, follow-up has been limited, accountability remains weak, and impunity persists. Bottom line, an attack on a hospital should trigger consequences, not another statement of concern. And here are some examples of key actions that can be taken in this regard. First, create a global health protection alliance, a standing platform of states, UN entities, and NGOs that acts in a systematic way when health protections are violated. The response must be diplomatic, legal, political, and operational, rather than another cycle of statements of concern. Second, reaffirm which humanitarian principles are sacrosanct and identify or update what's missing. Humanity and impartiality are non-negotiable foundations of humanitarian action. That is, relief based on need without adverse distinction. Neutrality and independence remain essential, but they are operational principles. They're not legal preconditions for protection under international humanitarian law. Today's crisis also demands 3 additional principles: do no harm, solidarity, and accountability. Third, use health outcomes as accountability indicators. Excess mortality, service disruption, and exclusion should trigger formal investigation. They should not be accepted as the inevitable cost of war. Our third recommendation is to fix the money. So humanitarian financing, we all know, is still too short-term, it's still too earmarked, it's still too donor-driven and too shaped by foreign policy. A local NGO field coordinator in Turkey articulated it this way: "This is a field largely shaped by donors. We do whatever the donor asks us to do. If a donor says that social support will not be provided, NGOs generally do not reject this." And that is the problem. Funding decisions too often determine what counts as need, instead of need determining where the funding goes. Humanitarian financing has increasingly become a foreign policy instrument. Bilateral and interest-aligned arrangements are expanding and becoming transactional, while multilateral humanitarian financing is getting cut. So humanitarian aid must follow need and not politics. And again, for this particular recommendation, here are some examples of key actions. First, create an independent, multi-layered, pooled humanitarian fund with governance separate from bilateral donors and UN agencies. Allocations must be based on assessed need and equity, not institutional mandates, donor preference, or visibility. Second, expand cash-based assistance. Because the evidence is strong on the fact that cash gives people agency, it strengthens local economies, it's often more efficient, and it's not uniquely risky. In-kind assistance can also be diverted. It's not just cash that happens to. So the issue is not the modality, it is the targeting, the monitoring, and the accountability. Third, integrate humanitarian financing with national health insurance and social protection systems. Parallel structures, they're costly, they're duplicative, they too often exclude displaced people from systems that they're entitled to use. And then fourthly, use innovative financing tools, including responsible private sector engagement. Anticipatory financing, blended finance, disaster risk insurance, and public-private partnerships are useful starting points, but they must be adapted for conflict-affected and displaced populations. Our fourth recommendation is uphold health for all. Universal health coverage is one of the great global health commitments of this century, but crisis-affected and displaced populations have too often been treated as a humanitarian carve-out, managed through parallel systems instead of being included in universal coverage. Parallel systems become permanent obligations. They're expensive, they duplicate national capacity, and they leave host populations behind. A refugee in Azraq camp in Jordan told us the following: there are many Syrian refugees in the camp who are in the medical fields. Nurses, doctors, pharmacists, dentists, and lab technicians. If they were given professional practice licenses, they could work within the community and help improve services. And the fact that that's not happening is a policy failure, but it can be fixed. Bottom line, war does not suspend the right to health. It makes it more urgent. And on to key actions for this recommendation. First, make the right to health the test for every decision. Service delivery, coordination, and transition should all be judged by one question: does this expand equitable access for those most in need? Women, children, and older adults, and people with disabilities must be prioritized, not left to the margins. Second, ensure continuity of care and connect it to national systems. Trauma care, safe delivery, vaccination, mental health, chronic disease care, and rehabilitation cannot wait for the crisis to end. Humanitarian health services should align with national health systems from the start. And third, treat attacks on healthcare as crimes, not tactics of war. Protecting hospitals, clinics, ambulances, patients, and health workers is a shared obligation across states, across non-state actors, and across the humanitarian system. And then fourth, build systems for climate shocks and responsible technology. Conflict and climate shocks are no longer separate emergencies. Technology, particularly AI, has huge potential, as we all know, but only if it's used with safeguards for equity, for data protection, and human oversight. Technology must serve communities and not extract from them. So the diagnosis made by this commission is clear. Incremental reform is not only inadequate, it is futile and it is dangerous. It gives cover to a system organized around donor control and not around lives. However, the current extremely difficult and dispiriting circumstances that we find ourselves in now also create a rare opening. The humanitarian reset, UN initiative, the Accra reset are all happening at once. For the first time in decades, the system is unstable enough to truly be remade. And the question is whether we use this moment to protect the status quo or to build something better. A health professional in Syria told us the real issue is that some donors not only expect you to remain neutral, but also threaten to suspend your funding if you show any perceived bias towards the victims. And that's the system that we currently have. The 533 lived experience voices that shape this report are not waiting for another reform discussion. They're waiting for protection, accountability, and a system that treats them as equal actors. And so this commission is not just a diagnosis, it's a demand for transformation and a blueprint for action. The Commission is calling for every one of us to act. We have developed policy briefs for different constituents. So we have them up on our site for affected populations, for national and subnational authorities, for local and national NGOs, for regional bodies, for international NGOs, for the UN and multilaterals, for donors, for academic and research institutions. I know that everyone here falls into one or more of these categories. And we hope that you'll have a chance to look into these materials that are freely available online. The full report is published in the Lancet on the CHH Lancet Commission website. The QR code is on the screen. It will take you to it. I'm going to close now. I see that we are a little bit beyond our time. I'll close with the voice of a senior NGO staff member in Turkey who said, after addressing immediate needs, the momentum waned. Promises were made, but once the initial phase ended, support diminished, leaving people feeling abandoned. For every one of us in this room, our job is to make sure that this time the momentum does not fade. My last word is that this is a once-in-a-generation moment to transform humanitarian health and assistance, and we must seize this moment together. Thank you. Thank you very much. As I mentioned, for those of you who were not here at the beginning, just to let you know that your agenda is on the seat. From the agenda, you will see that from here, we are going to proceed into inviting up our keynote speaker. I will first introduce the keynote speaker. We were meant to have two keynote speakers today, one from the Department of Refugee Services. They have sent in their apologies. They mistakenly thought that this meeting was taking place on Thursday. But it is my pleasure to introduce our keynote speaker for today, who is here. And before I do that, let me just say that if you're a speaker here today, so either you're giving a keynote speech or you're on the panel, we reserve seats on the front row for you, please, so that there's not a whole lot of disruption once you move to the panel. So please feel free to come up front and find a seat. I would like to have the pleasure of introducing Mr. Martin Manteau to you. Mr. Martin Manteau is the head of the Strategic Planning and Management Service at the UNHCR Regional Bureau for Eastern and Southern Africa. His extensive experience in humanitarian operations has spanned over 2 decades. At the UNHCR Regional Bureau in Kenya, he is responsible for regional strategic planning, resource management, and operational coordination, including monitoring emergency preparedness levels and ensuring that country operations comply with UNHCR rules and regulations. Now, before joining the Bureau here in Nairobi, he served as the Principal Situation Coordinator in the Mekelle Tigray region of Ethiopia, where he was at the forefront of managing and coordinating UNHCR's emergency response to the Tigray crisis, as well as to the Sudan emergency. Prior to joining UNHCR, Mr. Martin Manteau worked in the private sector as a corporate accountant and finance manager. We're very thrilled to have you today. We can exchange places now. Welcome. Shall we give him a round of applause?
Thank you, Chichi. I didn't know you did so much research on my bio. Again, thanks very much, Chichi. I think while listening to you, I'm quite related to a lot of the points that you're making. But my focus today will be to give a keynote speech. This is actually on behalf of the Regional Director, Mamadou Diambalde, who could not join us because he's traveling to Ethiopia to join the High Commissioner for World Refugee Day and a whole host of other activities. So let me start by just saying that perhaps I'll be focusing on a very key element of some of the report's recommendations, particularly along the lines of the way we respond to health emergencies. So, good afternoon, ladies and gentlemen. Let me begin by thanking the organizers for convening us at such a critical moment and for the opportunity to contribute to this important discussion. I would also like to acknowledge the presentation we just heard. Again, very deep and touches on a number of the issues that we are so familiar with. And we hope recommendations will inform immediate action and a drastic change in the way we respond to health challenges and health issues in displacement. These recommendations have laid out clearly both the scale of the challenge we face and the bold recommendations that have emerged from the Lancet Commission. We are meeting at a time when the humanitarian system is under unprecedented strain. Across our region, we are witnessing a convergence of protracted conflicts, record levels of forced displacement, shrinking humanitarian resources. These are things that we talk about daily. And an increasingly complex political environment. We go from Sudan to Somalia, from the DRC to South Sudan. Millions of refugees and internally displaced people continue to depend on humanitarian assistance for their survival. These crises are no longer short-term in nature. They are prolonged, cyclical, and too often normalized. I mean, here in Kenya, we have a Dadaab camp, we have Kakuma. These have been here for 3 decades. We have health centers there that at the beginning perhaps were thought of as temporary. You go to Ethiopia, right around the country, you have refugee camps with setups that have been there for 3 decades. Kabibea, Sheda, Albari, Kambela, the list is unending. So, as I was saying, they are prolonged, cyclical, and too often normalized. At the same time, the needs continue to outpace the collective capacity to respond, leaving far too many vulnerable people without the support they require. The recommendations we've just heard are both timely and necessary. And thanks for highlighting them so eloquently, Dr. Chichi. They reflected a growing recognition that the current system is struggling to keep pace with today's realities. They challenge us to think differently about how we design, how we finance, and deliver humanitarian responses. But perhaps most importantly, they challenge us to reflect on our own roles within the system. This is not simply about what needs to change in theory. It is about what each of us is prepared to change in practice. And we saw the various groups that Chichi put up there. Each and every one of us here belong to one of these groups. What is clear is that incremental adjustments will not be enough. The scale and complexity of today's crisis require more fundamental transformation. In many refugee hosting contexts, we continue to see parallel health systems. Again, the good doctor talked about this. These parallel structures were never designed to last, yet in protracted crisis, they persist for years. And sometimes even decades, just like I try to explain. These systems are expensive to sustain, and they leave refugees dependent on the continued presence of humanitarian actors in the country. At the same time, refugees continue to face barriers to accessing national services, whether due to policy, financing, or capacity constraints. If we are serious about change, we must move forward more towards inclusive approaches that strengthen national systems while ensuring equitable access to services for both refugees and host communities. And that is exactly what UNHCR is doing. Across the region, many countries are well advanced in including refugees in their national systems. This is no longer aspirational for us. It is happening. Governments across the Eastern and Southern Africa region have made commitments for inclusion at the Global Refugee Forum. And more importantly, they are acting on these commitments. Similarly, in several countries, we have moved to transition from parallel services to government delivery. Work is underway right now in countries like Ethiopia, Kenya, and Uganda to fold refugee services into national budgets and governance. This is a real test of inclusion. It is technically demanding, and it will not happen overnight. It requires a phased, deliberate transition. It also requires government leadership and financial support from development partners, so that the burden is not just transferred to the government. All of us, UN agencies, NGOs, must be on board and support the transition. And during my introduction, I was referred to as having coordinated the Sudan emergency. And I will share a little anecdote of working towards inclusion from what we call solutions from the onset. Where in the Amara region of Ethiopia, we had 25,000 Eritreans displaced from the Tigray region as a result of the war. We met with the community leaders in an area called Alamwash, where we set up a settlement for this group. In order to ensure that they have health facilities, we said, no, we're not setting up parallel systems. In Ethiopia, they have health posts, they have a whole structure. So we work with the local authorities, the regional authorities, to expand these facilities so they can be used by both the host communities as well as the refugees who were arriving. And it was very effective. Not only did we ensure that it brought about social cohesion, but also reduced the cost of providing health services by way of just helping the existing facility to be expanded to accommodate the new arrivals as well as the host community. And the host community were thankful for it because it meant they got services, it meant they got better services and so forth. We did the same in the Wash area. Okay, so just an anecdote there. And this is, I think, to underline the point that parallel systems have never been effective. They are costly and wasteful. So the best way to avoid the cost and difficulty of transition is to avoid building the parallel systems in the first place. And we are doing this in UNHCR as I speak. It is one of our strategic priorities as a regional bureau. Hence, where it is possible, even in the earliest, most acute phase of a new emergency, we are working to apply what we call solutions from the start approach, which entails including refugees in national systems from the very onset of an influx. And I think I've given you the anecdote. One of the clearest examples in our region is Ethiopia's rural settlement. Again, one that I worked very hard to do. And this is for the Sudan emergency, not the Eritrean population. Where from the onset of the crisis, Sudanese refugees have been included in national services, working hand in hand with local authorities and other partners. It will not be possible everywhere, and emergencies will always demand rapid, life-saving action. But where the conditions allow, designing for inclusion on day one is faster, cheaper, and more dignified alternative. This brings me back to the issue of funding. These transitions will not succeed on humanitarian funding alone. Inclusion that is lasting requires sustained, predictable, and multi-year development funding. It means engaging multilateral development banks, bilateral partners willing to invest in transition and self-reliance over the long term. And it means crowding in the private sector. And I think, Doctor, you talked about all this, so allow me to emphasize, okay? De-risking investments so that displaced affected regions become places where capital flows, where markets function, and where refugees and hosts can find decent work. We are extremely grateful for the many partners, including the World Bank, the Netherlands Prospects, Germany, the EU, and many others who have joined us in this endeavor by bringing concessional financing to governments and refugee hosted areas at the scale that national systems actually require. This is a shared responsibility. It rests with all of us, UN agencies, governments, NGOs, donors, academic institutions, and communities themselves. Each of us has a role to play. The question we should be asking ourselves, particularly after hearing these recommendations, is simply, where does this fit, or where does this shoe fit? Where in your own mandate and institutions can we take concrete steps to do things differently, commit to doing things better, and to contribute to meaningful change? This may mean advancing more inclusive policies, strengthening national systems, ensuring more predictable and flexible financing, and doing more to amplify the voices of displaced populations. No single actor can address all dimensions of the challenge, but everyone can and must contribute. Everyone can and must contribute. This is at its heart a call to work across the humanitarian, development, peace-building nexus. Displacement is rarely temporary, as we saw before. In Eastern and Southern Africa, the average time in displacement is 15.5 years. That's a long time. And our responses must reflect this reality by linking immediate humanitarian action with longer-term systems strengthening and development investments from the very start, just like the example I gave you. That requires stronger partnerships, greater trust, and a willingness to move beyond institutional silos. It also requires that we listen more closely to refugees and host communities, whose experiences and perspectives must shape the solutions we pursue. As we move into the panel discussions, I would encourage all of us to engage in the recommendations, not only conceptually, but also through the lens of our own responsibilities and capabilities. The success of this report will not be measured by its analysis alone, but by the extent to which it influences how we think, how we collaborate, and how we act. So let me close with this. The progress is real. Countries are including refugees. on a very serious note. Here we have the Shirika plant in Kenya. We have the Makatet in Ethiopia, which will be launched in the next couple of days. In Uganda, we have very inclusive policies. So it is happening, but progress is fragile. And it will stop without the required finance. This is a moment that calls not only for reflection, but for commitment. A moment to reimagine elements of the humanitarian system so that it is better equipped to meet today's challenges. A moment to reaffirm that health remains a fundamental right, including for refugees and displaced populations, even in the most difficult of contexts. And at the moment, for all of us to take responsibility for driving change, however large or small our role may be. Let us therefore move forward with a shared sense of purpose and a collective determination to ensure that no refugee, no displaced person, and no vulnerable community is left behind. Thank you.
Thank you very much, Mr. Mantle. Can we give him another round of applause? In line with our simple agenda, we're going to go right into our panel. If you are a panelist today, would you mind taking your seat according to this slide that I have up here, if you don't mind? So this is a game of figure out who you're speaking with. Wait. Anyway, slide. And then I'll sit in whatever seat is in. I sort of thought I would sit at the edge. Would you mind if we move down this way? Thank you very much. I know that we have questions and comments. The time is almost here. Thank you once again, Mr. Manto. I'm going to start by introducing our panelists. Thank you very much to all of you for being here. Can you hear me? Yeah. Okay, we're not quite seated the way we should be, but okay, I guess we can live with that. So I'm going to start by introducing Mr. Barnett Colley Jaji. If you don't mind just raising up your hand, Mr. Jaji. Thank you. He is the Executive Director of the Refugee Consortium of Kenya, where he provides strategic leadership in advancing the rights, protection, and socioeconomic inclusion of refugees, asylum seekers, and displaced communities. He's also the chair of the NGO Refugee Group, which is a coordination body of national and international NGOs working in the refugee space in Kenya, where he also led strategic leadership on key humanitarian and development issues. Thank you so much for joining us. And we also have with us Monica Camacho. Hi, Monica. She has more than 2 decades of experience with MSF, and she's currently MSF's humanitarian representative, in East Africa, where she has provided field leadership. She's coordinated MSF programs across East and Central Africa. She has managed security risks, negotiated humanitarian access, advocated for the protection of medical services in conflict zones, and worked to strengthen humanitarian response systems and improve access to healthcare for populations affected by conflict and displacement. And right next to me, I have Dr. Emily Koiti. Dr. Emily Koiti conceived, co-founded, and stewarded the South Sudanese Women in Medicine as its inaugural executive director. She's a South Sudanese medical doctor, health policy and systems specialist, leadership coach. She's also the Strategic Partnerships Director at Juba Strategic Consulting. And she's a next generation scholar with the CHH Lancet Commission on health, conflict, and forced displacement that we're discussing today. We also have Mr. Joe Mvalo. Thank you so much for joining us as well. He serves as the Deputy Secretary General for programs at the Kenya Red Cross Society. He provides strategic leadership for one of Africa's largest humanitarian and resilience portfolios. He oversees the design, implementation, quality assurance, MEL, and accountability of multi-sector programs that are delivered across Kenya's 47 counties through a network of more than 300,000 volunteers and members, reaching millions of people annually. He's also the director of the National Society Development and Localization Hub. It's a regional platform that advances peer-to-peer learning, institutional strengthening, and knowledge exchange among African Red Cross and Red Crescent national societies. And through his role, he supports localization efforts, organizational development, leadership strengthening, and the scaling of locally led humanitarian action across the continent. I'm also pleased to introduce at the very end, Dr. Orit Abrahim. Dr. Abraham is a general surgery resident at Massachusetts General Hospital. She's also a research fellow at Harvard Medical School, where she works on health systems, surgical care, and health delivery in complex emergencies and among displaced populations. Dr. Abraham is a next generation scholar with the CHH Lancet Commission on Health, Conflict, and Forced Displacement, and a key contributor to this report that we're launching today. So I'm sure you agree with me that we have the right people to delve into this a little bit more. We have 2 questions for each panelist. I'm going to start with the first round, and then have them zone in on the second round on specific recommendations. I'm going to start with Mr. Bartlett Kolejaji, Refugee Consortium of Kenya. And I'd like us to talk a little bit about localization. And so my first question to you is, I mean, it's one thing to talk about localization, but what would meaningful localization look like in practice? And what mechanisms are needed to transfer real decision-making power, resources, accountability to displaced and conflict-affected populations? And I'm giving everyone about 3 minutes, just so that we can make sure that we have time left over for Q&A and for some refreshments. Thank you.
Thank you. Thank you, Dr. Chichi. I had mixed feelings when I was seeing the presentation. Listening to your question, for a very long time, I represent a national organization. I think localization has been about participation. Oh, they have participated. That's it. So it is a defining moment listening to this. And for us, if I look at unpacking what localization will mean for us, is the challenge today is no longer simply whether we can respond to crisis, but it is whether our systems are designed to remain relevant, legitimate, and resilient in an era of protracted displacement. Kenya as a country, and I think Mr. Martin said, it is a protracted crisis. We have different actors, both international, and I would not want to repeat. The figures were there, and it is not rhetoric. That is the reality. The funds come, and a little bit apportioned to the national. Now there's a new model within the refugee space, the refugee-led organization. There is another layer that has been created. So there is a lot of fragmentation, and this kind of brings about where we need to talk of the systems that needs to be created. So you ask me about localization, it takes me back to the next feeling. A lot that is going on in this space, but again, it gives us an opportunity. And I want to talk about Kenya as a country. Our colleague from UNHCR did mention that Kenya, we are now shifting from the humanitarian system to actually going into integrating refugee issues into the national system. It's a huge transformation. It's a huge achievement. We have the Refugee Act of 2021. We have its regulations that operationalize the law itself aligned to our constitution. It's a great opportunity. We have a devolved system of governance, and some of the core sectors, one of them being health, it's a devolved service. It is an opportunity as a country. So when I'm looking at what really is localization for us, it's bringing all these stakeholders together. The national government, the sub-national, the county government, and also looking at the actors, refugee-led organization, international organization, and the national organization. So it's a holistic approach. It is not about fragmentation. So just to provoke the initial thoughts, allow me to submit that, and then later I'll be able to unpack. Thank you.
Thank you very much. A lot to unpack there. Thank you for getting us started on, Mr. Jaji. I'm going to move to Monica Tanacho. Do you have the mic? You can pass one down. Oh, there you go. So MSF, clearly a really important entity in this space. MSF has worked in complex settings across this region for decades. And so my question is, based on that experience, what are the most significant health impacts of conflict today? And what needs to change in the humanitarian space to address them?
Thank you. Thank you. Yes. Thank you. I think it has been mentioned in the previous speakers. We are talking about crises that are interlinked, situations that involve climate shocks, multiple displacements, very weak health systems, and the increasing reproduction of funding. And all these elements are having a massive impact on health and populations. I think as well it's important to bear in mind that I think each location, I would say, or each crisis will require a different response. So we cannot, I think one element that needs to be highlighted is there is not a one solution fits all. So I think there are different approaches for different locations. Some of the main areas that we are witnessing at the moment is a collapse. First of all, collapse of basic health care as a main driver for increasing of mortality. So it was mentioned how, for example, the Sudan health system has almost more than 50% collapse. And this is not only due to the conflict, but even we were operating in Sudan before the crisis, and already it was a very weak system. So we are witnessing health systems that are collapsed. We have a second point on access to healthcare is deliberately obstructed. So security restrictions are major barriers preventing populations from accessing life-saving healthcare. A third element is the mass and multiple displacements that communities are facing in protected areas and regions that are hard to reach. In the region, we have some of the larger IDP, globally some of the larger IDP numbers, and camps and settlements where populations are stationed are lacking basic services. And this is making them more vulnerable for outbreaks, epidemics, malnutrition, other conditions. Another element that we are witnessing is severe food insecurity and malnutrition. There are around 10 million people that are facing severe food insecurity, and some of the main drivers are insecurity and climate shocks, confounded with reduced assistance. And we are considering malnutrition as a medical emergency. And we are witnessing as well high rates of malnutrition and anemia among children, but as well pregnant and breastfeeding women. So this is an area of concern that is not spoken of. Another element is that disease outbreaks and epidemics are clearly more frequent, more often, and more prolonged. So we see more outbreaks of preventable diseases, measles, diphtheria, but as well cholera outbreaks. This region particularly are never ending. The MSF teams are probably the different ministers of health are constantly responding to cholera outbreaks. It's a never ending story. So cholera seasons are on. Now it's becoming a more constant situation. So this requires that everybody adapts responses. We see as well results of collapsed EPI systems, so vaccinations are not any longer present, poor access to water and sanitation, displacement, and all these elements are mainly due to conflict. And as we all know, disease outbreaks have no borders, so we are looking at cross-border situations. Another element that we are monitoring very closely and responding is mental health, sexual violence, and chronic illnesses. So really it remains, this element remains very high in communities that are repeatedly exposed to violence, cycles of violence, displacement, and lack of assistance. Chronic diseases as well, and care for NCDs, HIV are cut off, increasing mortality and resistance in many cases. We're talking about doctors and pre-medical people. We are monitoring very closely the increase of antibiotic resistance, MDRs, as collapsed health systems are continuously broken supply chains. And we see patients having superbugs in remote areas of South Sudan, and it's becoming a harder situation to live with. And I will finish this part with the attacks on Dimensional Resolution 286. It's now 10 years of anniversary of the resolution. So for sure, attacks on health, medical facilities and attacks on health are a point that is in conflict. It has become really a more recurrent and concerning situation. So that will be the first part of the question. Those are some of the highlights that we are seeing in conflict settings. What should be changed on that response to address some of these points? I think it's needless to say the protection of healthcare. It should remain top priority on all agendas. As well, a key element is improving and increased access to healthcare for people and communities in need, including and expanding access to humanitarian assistance. Some of the areas that we think we should be focusing is, as mentioned, all community engagement, community and not only led, but integrated and local adapted. We are working on healthcare models for the most vulnerable people, including women, children, elderly and disabled populations. So it includes community to be part of systems, how to deliver packages of health, providing comprehensive and continuum of care that meets a minimum standards of quality, and rather disease-specific focus. So we are really in all our programs trying to change the approach and try to see how the community becomes a key player in delivering more comprehensive packages of health. I'm jumping to the second question, right?
Not to the
Not
second
yet.
one.
Okay.
Yes, but thank you. Thank you very much for taking us through that. I'm going to move to Dr. Emily Koiti now, sorry. Maybe we'll pick up a little bit from where Mr. Judge dropped off, but in your experience as a medical doctor, peace builder, human rights activist, and co-founder and founding executive director of South Sudan Women in Medicine, what lessons have you learned about how localization works in practice and what are the key challenges?
Yes, thank you very much. Mentioned that earlier that what continues to come to be prominent is that localization is so much about participation. In South Sudan, with all those hats that have grown over time, the paradox of localization is that the people closest to the problem who experience it do not have the power to make decisions about how solutions to their issues are going to be delivered to them. In the report of the Commission, we have emphasized why it's important to recognize locally trusted actors. Those do exist, but they are seen mainly as subcontractors, that they are trusted to deliver programs where the boots get on the ground, implement programs, but they will not decide the how, they will not be seen as capable of managing resources. And oftentimes also, those resources, if they're going to get to them to implement those programs, it's going to be through intermediaries. So then there is a delay of getting the needs of populations like refugees and internally displaced persons, and even host communities, programs on time because of all that bureaucracy that is existing right there. And for me, that is what stands out, the interest of time.
Thank you, Emily, for emphasizing those important points. I'm going to turn to Mr. Joe Mbalo, Kenya Red Cross. And of course, the Kenya Red Cross has operated in this region, since the 60s, as the current Deputy Secretary General of Programs within this institution. How may the Commission's call to reemphasize humanity and impartiality, to elevate solidarity, and then it's called to do no harm while strengthening accountability and so on and so forth. How could all of this resonate? How might it resonate with national organizations, and particularly those within the national societies?
Thank you very much. First, just on the observations of the report and the recommendations, particularly this, I want to really appreciate that. For us as a national society, I've had the privilege to serve, as you've mentioned, in an organization mandated by law and by the people of this country, to be there before, during, and after any of this crisis. So as a national society, we've been here since the Gala, the Turbi massacres, the post-election violence, conflicts, the inflows of migrants from the neighboring countries, from way back in the Ugandan and Tanzanian crisis of the 70s. And this basically, the call of this report resonates with what the Red Cross movement is actually anchored on. The principles of humanity, the principles of neutrality, the principles of impartiality, and very importantly, what is mentioned in the report around the do no harm, which has been mentioned by a few of my colleagues here with regard to what impact it has on those that are affected. A very simple administrative decision of deciding to direct aid through proxies. And our direct observation, and sadly, because of that, has been that a lot of the fatalities and the deaths that the report highlights are not actually caused by the violence. You mentioned my colleague here that a lot of this happened as a result of the health system's failure and service provisions that are not available. And the call for doing no harm, even in going on with the current mood of amongst the nations that are and the parties that are in a position to assist, being able to direct that support as close as possible to those persons then has a very huge impact on that, because it is those as close as possible to the communities that can be able to observe basic response laws of being able to reach those affected in as short a time as possible. It also addresses the concern that the rest of the world in this polarized situation is in around value for money and whether the tax dollars are actually getting to the people that are there. So those directly then impact the outcomes. And one of the best parts about the recommendation report around then being able to leverage on health outcomes as a means of accountability. Do we measure then as agencies working in this, whether we are governments, we are donors, we are humanitarian agencies, what impact we have on people's dignity, what impact we have on service provision, then that answers that question. But then from where we stand, we feel that this validates these particular principles. They are not abstract principles. The examples given in the report and what is coming across from my participants and what is our lived experience is that it is not very easy being able to observe these principles, to be neutral, to be partial, to only give services based on the needs of the people that are affected, with all these other interests, whether political or otherwise. And as much as we are looking at a reset of how things have been over the last 8 years, those fundamentals do not change. The people we are talking about here are numbers. For us, it's actually a very sad realization, and we are hoping that we'll move from just documenting the breaches. For us as a movement, as a Red Cross movement who is in the front line, in the years 2024, as you've shown here, in 2025, we have lost higher numbers of volunteers and health workers than we lost in the combined years of the First and the Second World War. That is not normal. So then the challenge becomes then, and we are very happy with the recommendation around figuring out a mechanism of calling each other to accountability. And when you talk about this, we're not just talking about just the humanitarian actors or the donors or the recipients of aid, but even for the armed actors, that we need to move that conversation further. And we have faith that with goodwill that these calls are calls that can be responded to and very urgently need to be responded to. Otherwise, then the humanitarian space, the providers of healthcare, then will not be able to conduct the services and give the services that are required by this population. So we really allow these recommendations, and we hope that then they all come on board to look at them to allow this to guide us moving forward.
Thank you so much for those powerful comments. A lot to dig in there, into there. I'm going to move on now to Dr. Orit Ibrahim and then come back to every one of you with a final question. Dr. Ibrahim, the Commission argues that humanitarian financing needs to move beyond emergency response and become more anticipatory, more locally accountable, more supportive of long-term resilience. So first of all, what does that transition actually look like in practice, particularly in countries experiencing protracted crisis?
Thank you for that question, Chichi. Can you hear me? Okay. I think we've mentioned this before, protracted crises are no longer an exception, they're the norm. So when we look at 2024, over 90% of those coordinated appeals were from countries that were experiencing protracted crises. And when the Commission looked at the top 10 largest crises and displacement contexts over the last decade, they're still receiving inconsistent and unpredictable funding. And it's not only in the volume of funding that they're receiving, but it's also in the mix of funding sources that they're receiving. So development financing is decreasing, peace financing is still quite negligible. And humanitarian financing, however, is increasing because now it's filling those critical gaps in systems that states used to fulfill or development actors used to fulfill. We're also seeing that in like health, education, and WASH, this is where humanitarian actors are expanding beyond their remit. But these populations that have had humanitarian presence for decades are still not receiving reliable essential services. So we're recognizing that it's evident that this financing system that's been designed is not for these protracted crises, and it's not meeting the needs that it should be. It was created for acute emergencies. And so the architecture that we see now, we talked about this before, is short-term funding cycles. It's heavy earmarking. It's using multiple layers of international intermediaries. And it's struggling to maintain services in these contexts that require sustained engagement and long-term resilience. And then we're seeing that there's quite a bit of fragmentation between humanitarian development and peace financing, which is really disruptive in these protected crises. So the Commission, the way that we think about this is how do we design a financing system that can work across the crisis typologies and look at the existing capacities. So when we look at acute and acute on protracted crises, the latter, which is usually the norm, we still need resources to be mobilized quickly. And so the pooled funding architecture that we're proposing is one that emphasizes predictable and pre-positioned funding that can be more anticipatory and that can rely on early warning systems that are closer to communities that can be enabled by technology where that's feasible. Then it's also planning, again, from the outset for continuity of care. So financing should maintain essential public health functions. It should maintain access to primary care, and it should make sure that households are not absorbing the costs themselves. And so we're also, when we think about cash-based assistance and we think about pooled funding architecture, they're important because they increase flexibility, they're strengthening agency, and they're reducing the fragmentation across the systems. And then it's important that from the outset, displaced populations are included in these financing schemes that we're discussing. And then over time, we're thinking about financing that can make conditions feasible for transition and for system recovery. So it's reinforcing national health and social protection systems and not creating these indefinite parallel structures. It might look different in all of these contexts based on governance capacity, on existing systems and institutions, on the intensity of conflict, but it should create a path towards local stewardship. And so for us, the transition really means it's not just a sudden handoff from humanitarian to development financing. It's because we know that causes interruptions of services, it can harm populations. It's thinking about a model that can move away from responding to repeated cycles of collapse and start to progressively protect health, to strengthen institutions, and to expand locally led decision making across the crisis.
Thank you so much, Amit. I know that we have also started getting into the recommendations a little bit. And with the little time that we have left, I'm going to just have one more round of questions that I'm going to ask for very brief interventions on these, just so that we do have time actually, but just so that we keep within the networking and mingling and continuing the conversation over refreshments starting from around 5 p.m. I'm going to start with Mr. Jaji and ask about recommendation 1, which calls for inverting the power. What aspects of this recommendation resonate most with your experience at the Refugee Consortium of Kenya? In about a minute or so.
Thank you, Dr. Chichi. One of them, and I just want to be very direct. Last year we celebrated our Sigma Jubilee, 25 years. We've been having this short-term financing emergency where we keep talking of the outputs. 2 or 3 years ago, we did get a donor who co-created with us based on our own strategic plan. This has made a huge shift in my organization. And I think last year we had the stop work order. Among the urban program, my organization was the only organization that literally remained. We didn't lay off in terms of staffing, the infrastructure continued. We continued supporting both national and sub-national in terms of capacity strengthening. We worked with the refugee-led organization, and this really made a huge stride. So if you have to ask me, the first thing is trust us. Trust the national actors, the local actors, just trust us with the mandate. Because initially, all the implementation risks, and I remember during COVID, we remained as more of the front line, but again, with a lot of challenges. So one of the lessons I say is co-create, co-design, and trust us to implement. Then we are looking now into systems building. In the absence of all these other actors, it's actually the local who will be there. The colleagues from MSF, just another analogy, where we are talking of transition, I want to give a very good statistic from the Kenya National Bureau of Statistics. Over 70% malnutrition that is happening. Now we are moving our forcibly displaced population into the national system, which is being implemented at the subnational level. There's so much to be done in terms of that. So in parallel, in terms of, as we move towards the systems, but also we cannot forget the gaps that are already existing. This to us will be very key as the to have. Thank you.
Thank you so much for those really powerful examples. I'm going to come back to you, Monica, to ask about recommendation 4, which focuses on upholding health for all, and it addresses the continuity of care, climate change, and technology. What stands out to you the most in this recommendation? In about a minute.
In the case of continuity of care, I think it's important to continue stressing the short-term versus the long-term funding available. It's clear that the moment of emergencies are critical, but how to maintain and guarantee the continuity of care for populations, the most vulnerable groups. So this needs to be continued reminded. We see how ensuring continuity of care for vaccinations, EPA for children, SRH services will prevent for sure morbidity and mortality. So we need to find ways how to maintain that continuity of care. On regards to climate, we are all communities are constantly facing drastic and opposite shocks. So we have parts of the country facing severe drought and others absolutely flooded. So how to be able to maintain and strengthen services that are able to respond to multiple different crises at the same simultaneously. And on regards to the use of technology, how to better use AI, how to support the health system in the incorporation of modern tools or technological tools, but as well how to better predict and anticipate outbreaks. So there is a lot of technology that can be used to prevent mortality and morbidity using and promoting.
Thank you so much. And over to you, Emily. I think we'll focus on recommendation 4, which is upholding health for all. Kindly share your reflections on this particular recommendation from your vantage point.
Thank you. I deliberately bought my time and transferred it to this question because it's very important to me as a medical doctor. One of the most frustrating things when one is practicing, I think everybody who is a doctor here and has had to work in low and middle income settings, you can attest to this, that it's frustrating to have somebody come to you and you have all the knowledge, but perhaps because of where they've had to come from, they showed up late when they could have been diagnosed earlier. And that is because in their context, they could not get the first responders or people who would have seen them to diagnose them and not available. And that is characteristic of fragile and conflict affected settings, which is of course, South Sudan is part of that work. Health for all. when we made this recommendation, and even as I was thinking of coming here to talk about this, it's easy to get care to people who are easily accessible. But the true test of whether a humanitarian system is working or a health system is working very well is its ability to get to the most vulnerable, to the difficult to access. I'm going to give an example in point of a program that is failing with flying colours in South Sudan. It talks about pooled funding that my colleague, Dr. Orit, has just talked about. Pooled funding is a thing that has been happening in South Sudan. We had health pooled fund, those who followed, I believe MSF is aware of that, and the rest of you. And currently we are implementing a program called the Health Sector Transformation Project. That is one, I sit here as a doctor, as somebody who is intimate with the health system, and I can confidently say that it's failing. It's failing partly because of the things that we've talked about here. That somebody sat somewhere and thought this is what has to happen, but did not think of the context properly. In places like Gogrial, Warab State, up north, the state where our president comes from, that is a state that is rife with intercommunal violence. And that means you could stock hospitals with supplies, you could station a health worker there, but then people will not be able to access that care because they are fighting, and they will end up killing healthcare workers too, because nobody has gone to take now a peace program that is integrated with the health service delivery program to help them appreciate the importance of these services that are brought to them so that they can access and consume them. So then you have supplies that expire, that are wasted, and the cycle continues. But you also have healthcare workers who are put in harm's way because somebody did not think critically about the nexus of health, humanitarian, and development, for example. Which in our case, in that context, if somebody was thinking about that health service delivery, they would say, okay, we do have resources for buying supplies, for paying healthcare workers, for all of that, but we also need to integrate, for example, community peace dialogues about them getting to understand why it's important to protect these health facilities, how any mother who is in labor, if they have to deliver, is not going to choose whether they're fine. And eventually you could see that a health, trying to achieve health as a superordinate goal could also help solve a conflict problem on the ground. If only we were thinking that one, we could be able to deliver health for all, for those people who are often shunned when thinking about, even when they are picking the local NGOs that are subcontracted to deliver care in those regions, many of them will try to stay in the safe areas. That's already failing us in terms of delivering health for all. I still want to go on a bit. Just allow me. Yes. But, and I'm talking passionately about this because I worked under the thematic area of HDP, and that is Humanitarian Development and Peace Nexus. And yesterday I was on a flight with the managing director of an entity called Incomco. It started in Rwanda, if you've heard about it. I see somebody nodding, and it's now in Ethiopia, South Sudan, with over 11,000 beneficiaries. And I was really inspired and intrigued by the work that they are doing. 3 years down the road is when I got to know about it on a flight, even when I work in this area. But this is what they've done, which speaks to what we're recommending. That they do give loans to refugees, to internally displaced persons, because we do not know when the conflict in Sudan is going to end. For people in places like Reng, who need to continue their livelihoods, who are not thinking about the most immediate meal, they want to think about how their lives should also be in 10 years. So they need to be able to know how to continue to build their own, to be self-reliant and not depend on handouts. And that helps them. But also, I heard of something very important, which is, for example, if a mother is pregnant and she's doing business, she's given a loan that is has very low interest and unsecured And on the day she falls sick, she needs to get supplies, but she cannot get supplies for her shop, for example. These people are able to deliver the program of this Nkomko is able to deliver the supplies that they need to continue selling. If, for example, that's the same day they need to attend antenatal care. See, and that enables them to get help. Now, that's an example of a program that is designed to ensure that at no time should anything be more important than somebody's access to health. And I think these are some of the things that we are talking about. Some of them are being implemented as we echo them in the report, but over time, it's what we are saying in the report that it has to happen. And lastly, health for all is not going to be achieved alone. All the recommendations we made in the report are codependent. We cannot focus on one and forget the rest. If we are not going to hold political actors accountable, for example, in South Sudan, for destroying health facilities, MSF-run health facilities, and even killing healthcare workers, we are not going to be able to uphold health for all, for example. That is what we mean by codependence, and I think to be Thank you.
Thank you for those really important reminders. Thank you. I'm going to move over quickly now back to Mr. Mbalo, for some reflections on recommendation 2, which has to do with ending impunity, really from your vantage point as the head of Red Cross. Maybe you could share your reflections on any aspect of this particular recommendation for a minute or so. Thank you.
Thank you very much. So, with regard to ending impunities, I want to start from the point that Mr. Martin mentioned in his closing remarks around responsibilities that we all collectively have. And the responsibility that I feel that we all have as humanitarian agencies, as governments, as parties to conflict, or even observers, is the engagement that is being mentioned here, because it all comes down to access. And for us as the Red Cross movement, it's very simple. It goes back to the basic reminder to all parties in conflict that international humanitarian law is not a suggestion. It is an obligation by law, and all parties have signed up to this. So as we say that, we also take up that challenge, and the challenge provided for in the report, that we hold as national societies a particular advantage, a particular position that then we should also be able to leverage on with regard to serving as auxiliary to national authorities and having the mandate to access all parties as provided for by the Geneva Conventions. So for us, then it's a call for concerted working efforts together, even as we commit as a Red Cross movement, and with the mandate holders, the International Committee of Red Cross, for being able to follow up on parts of this crimes that are being spoken about and the impunity that is coming in. The point, as has been mentioned by Natari, is that we cannot continue allowing any of the parties to continue preaching this, because then it becomes normal. We're talking about now this very dangerous signs of health facilities being attacked and health workers being attacked, because when the first cases started around 2022, there was not enough outrage around it. There was not around discussions, but there was no engagement around it. We are particularly happy, though it's still very sad, that part of the supplies, medical supplies, facilities, warehouses that were taken up by in the beginning of the Sudan conflict are being handed over back to the agency. But the idea is that we have a collective responsibility to continue engaging these parties even before the facts, even before the conflicts. Otherwise, then by the time this has happened, then it becomes something else. One of the other things that I'm hoping that as we continue to implement and think through the very good recommendations made of this is then also thinking around, for example, the impact of technology. And we're talking about it in the good part of what it's used for in terms of cash programming and the like. But then also looking at programming, and we've started those conversations, we need to provide more forums to discuss them the impact of drone warfare, which is a new phenomenon now, and the indiscriminate nature of the damage that causes. And this is part of the reason why we're seeing a lot of facilities that are protected by humanitarian law, like health facilities, like centers where people are taking refuge, being abused because it is not particular individuals doing it. So we also then need to look at the provisions of IHL as it exists and be able to grow that to cover this element. But from where we stand, we are assured that this is something that we collectively, as governments, as humanitarian agencies, as citizens of the global world, we can be able to come in solidarity around these issues and make sure that we make this not something that is normal. We cannot keep coming to talk about figures of health workers that have lost their lives because of a crime of wanting to help.
Thank you. And last but definitely not the least, let me turn to you, Orit. How can reshaping humanitarian financing advance the Commission's recommendations that we've already discussed? Thank you. That is inverting the power. Thank you. Ending impunity and upholding health.
I think I'll just focus on inverting the power and ending impunity. I think it's clear from our conversations how financing can influence health service access.
Sure. I'm not sure if the mic is working very well.
Yeah,
is it another one?
Hello.
Sure. We can try that. Thanks.
Oh, yeah, that's right.
All right.
Yeah. So when you think about inverting the power, financing has explicitly concentrated power. So historically, 60% of humanitarian financing came from the US and from the EU. And historically, the US provided 40% of that just on its own. So we're seeing that a small number of very large donors are influencing the priorities based on geopolitical interests, and they're shaping where all of these resources are being allocated. So the way that we hope to tackle that with our recommendations is advancing diversifying donor pools. It's looking at more independent pooled funding that can allocate based on objective need alone and not visibility. It's looking at utilizing innovative financing instruments so we can consider things like concessional financing and leveraging other donor pools like the private sector. It's also, most importantly, advocating for increasing direct financing to local and national actors. And then we have seen this in civil society organization networks that are doing this on a smaller scale. So the NEAR network, the START network, these have all been successful at demonstrating that these types of pool funding architectures and direct financing can be possible. They just have to be scaled. And then financing is also quite important for ending impunity. So when we think about accountability, it shouldn't stop just at tracking where funds are going. It should also look at these new principles that we're elevating. So it should minimize collateral harm. It should be made in genuine partnership with local actors. It should be responsive to the needs of affected communities, and it should protect access to care. And that can mean increasing the transparency of allocation decisions. It's strengthening inclusive accountability mechanisms. And it's, as we mentioned, it's not just tracking financial outputs, it's looking at whether the financing is going to frontline services and whether it's improving health outcomes as a whole.
Thank you very much, Orit. Our audience has been extremely patient. First of all, so we can give a round of applause to our panelists. Much information coming out of this panel. You've been extremely patient. I hope you're not going to run anywhere because right next door, we have something planned right after this, but we do want to open up the floor now for any reflections, comments, questions. We will take a pretty long round and give some time to answer what we can, and then continue to interact over a small cocktail. We'll see how long we will give to this. But please feel free to just raise your hands. I think we only have two working mics, so you can use this one as well if we need to.
Good afternoon, everyone. My name is Michelle Wangari, and I have reason to believe I am the youngest in this room. I I am a university student, a law student in particular, but I do have an interest in diplomacy and international law. I'd like to direct my question to Mr. Mbalu. We have talked a lot about collective responsibility throughout various sectors, but my question is very simple. What advice would you give to the youth? What can we be able to do to help push the agenda of helping refugees within our country? Thank you.
Thanks, let's continue.
Good afternoon. My name is Barak, also local Salim, Humanitarian Organization. My question is for Ms. Monica and Mr. John Van. I believe if the others even have an answer for this, you will please answer of my application. Thank you. So my organization started recently and we're dealing in humanitarian sectors. And what we're really looking for is gender-based violence. So I didn't hear anyone speaking about it, as I hope you can educate me more about it. So I was really asking, there's no particular problem that has a higher level than others, but I feel like gender-based violence is really neglected, especially here in Kenya. And your insights on how we're supposed to go through it, how local organizations and small organizations like mine should look for funding, and how we should be able to effectively help people, and how we can get partnership, for example, like Red Cross and MSF would help local or small organizations, and how we actually do that. Thank you.
My name is Michael Kishombe. I have a bit of a political background, so I'm going to follow up on something Dr. Emily mentioned when you said it is very true that we need to hold political actors to account the attacks that are happening, attack on what also Mr. Joe, my colleague in the movement, mentioned about healthcare danger. So my question is, some of these issues we've been mentioning, of course, the recommendation. How much are we engaging these political actors? Because we might, looking at, even the audience here, I know we were supposed to have one of the key speakers from the government, but are we engaging these people because we don't engage them on some of these things? Who is the responsibility to engage them? And if the engagement has been continuing, probably, I may not have an idea. Has it been successful, or what do you think? Is it realistic? Yeah, so probably Dr. Emil and maybe anyone else who might have an idea.
Thank you. My name is Norma. My question is on the issue of health financing. You mentioned the basket kind of funding, but I think what we know and have seen is that funding across the board is diminishing, and worse with protracted crisis, funding is severely going down, and more and more players are moving to self-financing, social health insurance, and how do we utilize and tap into those models to include possibly displaced persons? And secondly, how do we ensure that we address the social determinants of health that Dr. Emily mentioned? We know a lot of our refugees or forcibly displaced people often are compelled by law to live in camp-like settings, are restricted to work, and so that also impacts on their health, because we know that for the generality of people, the public health services are often not enough. You get to a point where you have to pay out of pocket for a lot of other things, and if you are not able to work, you are not able to generate income, how then do you bridge that gap of what is provided by the public and what oftentimes individuals have to dig deep to finance in order to be able to get the health outcomes that they need. And so what is the thinking around that beyond looking at the models that you have presented, looking at the realities on the ground, how the changes on the ground, states are having to move and adjust in terms of health financing because the external funding is going low, and most of the times refugees, possibly displaced persons, are not high on the priority. Even when the funding comes, often the priority is citizens first and everyone else, and the possibly displaced people are the last in the queue, if at all. And so we need to think around other alternative models. Thank you.
Yes, my name is Barack Okeo. I am engaged in the social research sector, but I also manage to work with a number of INGOs in the region, especially in Kenya, Somalia. I was really interested in, it was mentioned that as far as again, the local actors should be getting quite a substantial part of health funding. But based on my personal experience, and I could give just one example, I do feel like the UN OSHA in Somalia has been engaged in pooling resources when we have emergencies, and quite substantial in health. But the challenge I noted based on as a reflection was that local actors sometimes we face the challenge of capacity in implementation, which makes philanthropies and even bilateral donors feel a bit more comfortable in channeling these funds to international agencies. So my question to the Refugee Consortium, Kenya Red Cross, and even to MSF, what could be some of the mechanisms which can be employed to enhance the capacity of local actors so that they can be better placed with more enhanced capacity to receive funding and ensure implementation? Because health is a bit technical, may be different from other humanitarian aspects like livelihoods or WASH. So I was just looking at what could be some of the mechanisms we can undertake to strengthen capacity of local actors. Thank you.
Looks like all the questions on that side. Okay, let's go ahead.
Thank you so much. My name is Hassan. Dr. Hassan from UNHCR. Thank you so much for the insightful presentations. They were really helpful. The important work behind this commission. If we look at the report calls for structural transformation of strong local leadership in humanitarian health. Yet, similar recommendations in the past have stalled, often stalled, due to political resistance, fragmented funding, and slow implementation. I'd just like to pose a question to all of us. What will make this different? And how can we ensure its proposal and recommendation lead to a real action rather than another set of unfulfilled goals?
Thanks. My name is Dr. Mary, and I'm a nephrologist at the International Hospital. Mine is just a comment and a question that in countries such as Kenya, where corruption is seen as a public health disease, how does the Commission framework where does systemic corruption fit, and what remedies should global health actors take and prioritize when corruption becomes such a major barrier to delivering care? Because these conflicts are going to kill visibly. It's corruption and denying patients access to medication and life-saving equipment that's killing silently. Thank you.
Any more, or shall we? Okay.
So, thank you so much. My name is Colin Soreki. I work with the Refugee Consortium of Kenya. Chair, if you allow, mine is not a question, but I'd like to help respond to a question that has been asked by my brother here. Now, working as a fundraiser in a local organization, I feel the question that was asked. But now, as a local actor, how is it that you can eventually grow and become sustainable? And there was also a comment here from an organization that is new. So, Audit, again, this was yours. I just wanted to maybe set the stage for you by sharing the experiences that we have had, this is in terms of a local organization gaining in terms of localization. So I think the first step where we local organizations go wrong is that we look at ourselves as competitors. There is an example, an organization that does basically what we do, and we have tried to reach out to them. For over 2 years, it has not worked out. So I think the first strategy is that, yes, the funds are not there, they are doing, but the best way to get it is to start to work with local minded organizations. More and more at Refugee Consortium of Kenya, a good percentage of our funding, which Alex said that is growing, is coming through consortia. So I just urge the local organizations, I know that the issues of capacity and staff, but the best way to start is to get into consortia, get this experience that the door wants, and then eventually you will be able to secure your own funds. Thank you.
Thank you so much. I know that that's just the tip of the iceberg. In the interest of time, I'm going to have us begin to respond to whichever one of these questions really speaks to us. We can have the microphone just go down the line. Thank you.
Thank you so much. I want to bring some questions into the context of Kenya. That's within my purview. When you sit with your legal team, they talk of purview, it's different and all that. One of the things we are trying to do now as an organization is reminding the government you have a responsibility. The domestic resource mobilization. Can you start allocating budgets on refugee issues because you have accepted them in our country? At the national and subnational level, we've been very influential in terms of the systemic level of change, the policy discourse. Last year, as a chief guest, the subnational launched a new standing order. Refugees can now petition the County Assembly of Turkana. Any matters to do with refugees, they can now go petition. So at system level change and national, we are now advocating, and particularly in the upcoming World Refugee Day. One of my roles will be to remind the government that we need an autonomous Department of Refugee Services with its own budget, with its own staffing. That is my message for those who will be attending, and that has been our message. So I'm looking at the systems level change. The other issue is the social. The GBV issues within the subnational. Initially, GBV has been on the rise. Maybe for no reason, the maslaha. My team are working on the anti-FGM bill. We've now combined the alternative justice system, one of the social transformation model, but also at the same time, we are looking at the medical legal intervention. We make sure the culprit is taken to the last mile until when they are jailed. Non-negotiable. Protection is non-negotiable. They do no harm. So for me, it's not a linear process, but it requires a lot of integrated approaches to this. I agree with my colleague. The way to go is more of consortium. Competition, you are going nowhere. So, and one of the mechanisms is the co-creation that I mentioned and the co-design opportunity we got. There are donors now who are able to actually look into what you want, what does the community say. We are moving into a space whereby our organization will be even funding the refugee-led organization as minimum as $25,000 by each organization. And this is really helping us. We do not have a big workforce, but now the frontline service providers are the communities that we work with. This is easing our work so that we remain focused at the systems level, trying to look also into matters to do with advocacy, the pool funding. We talked of Somalia. Kenya has no humanitarian pool funding. There's a new resident coordinator. We are now trying to come up. I think Red Cross can be able to unpack that for us. Then also the climate adaptation funding. For us, we are now pushing for that. Climate-induced displacement is real. It's not only about conflict. The word impunity as a person provokes me looking at the East African community. We are the consumers and producers of these people. And they keep shaking hands, taking photos, as if no. So at a personal level, we really need to also have the voices of the refugees themselves having this conversation. It gives it more moral authority and the legitimacy. So to me, those are some of the areas. And yeah.
Thank you. We can have the mic. Do you want to go back? And then we'll come down the line. Thank you.
Yeah, I can touch on the question on financing. In the commission, we highlight an example of Colombia, and it's really important to push for successful examples that we see there. So regularization of refugees in that context was particularly impactful. It reduced multidimensional poverty. It was more cost effective. It was improving health outcomes, and it was contributing to the market. And it's showing that in regularization and inclusion into national health and protection systems can do a lot more with even smaller funds that we're seeing now. Because what we're seeing now is that intermediaries, there's a lot of administrative burden, there's a lot of loss going through multiple international actors and multilateral agencies before it really reaches individuals. Cash is also important in this, so our recommendations are interconnected as well. Cash can be used in the acute period, but it also, again, can build in long-term resilience, looking at 10 years planning, looking at how it can feed into social protection systems and transition into a national system as well, not just in the hands of humanitarian actors.
I'll start with the very direct question about what we would advise to do with the issue of migration, what they can do as a cohort and as a capacity. And I will be very practical, copying from the events or just to show how much power they have in this country. There will be a celebration that a lot of people are not looking forward to next week. That was brought upon us by the youth. I'm very proud of parts of that, and the part that I'm proud of before I'm accused of being a politician is because we broke the world record. There was created the largest medical volunteer workforce we have ever seen in sub-Saharan Africa. 3,000 medical doctors came together, and they did very good. Of course, they were doing this for the first time. They had a few issues about access and their safety. We unfortunately lost 2 doctors in the process, which was very sad. But the way they mobilized to get those 3,000 medical officers and have a mobile unit in CPG supporting the young people who are rioting, that was something that we've never seen. We have had engagements with them since, and we are happy they are now mobilizing into a voluntary system that can work, that we'll be very happy to support for that particular part of them providing essential services during such critical times. But the point I'm trying to make is the power of social media and how the youth in Kenya are using it is phenomenal. For about 3 hours, even we who have access to every part of this country could not access certain parts of the CBD. We became persona non grata. We got accused of a few things. and we could not move for a couple of hours, which was very sad. And the point I'm making is the role that the youth can play, because that is their system in managing misinformation. Now, with regard to migration and refugees and the problems coming to us also next year, our biggest challenge during the electoral process of this country, which becomes quite violent, is the misinformation and the spread of negative ethnicity messages that runs around this country. It used to run around on pamphlets. Now we are worried with the way social media is being utilized, that will become catastrophic. So then copying of the bad behaviors that some of our African brothers and sisters are using, those kinds of things and the discussions going on in our social media platform is another concern that we're starting to have, because there is a lot of profiling of ethnicities, of nationalities, and that can go out of hand. So what can the young people do? Be able to play their particular role. We're not asking you to be the diplomat for all the peace building, but then your opinions and your participation in those forums in a positive way really has a huge impact that you not. So that would be particular advice. But for those that are now organized into entities and they have organizations that are youth-based, whether they be GBV, whether they will be youth, then by mandate of law under Cap 256 of Kenyan law, we have an obligation to support you as a Red Cross. So then we will be very happy to answer also the question around the capacity building on GBV programming, what can be done, supporting any kind of access and building that capacity. Then we'll be very happy to support you with that. We work very closely with the networks that are dealing with also refugee and migration programs, even across the borders, under the International Center for Humanitarian Affairs. So any particular capacity development support that would be required, we'd be very happy to provide it. It is not a favor that we'll be doing any particular agency. It is an obligation that we have. So we'll be happy to support this particular
thing. I will touch the sexual violence, gender-based violence, and question on the influence of political actors on the protection of medical mission, and touching a bit on corruption. I did mention mental health and sexual violence are elements that are realities that are very close to our programming, permanent, transversal points. So any of our medical teams are trained and prepared to really be able to provide first aid care and try to identify what are the most urgent situations of COVID. We have been, probably you have been seeing our reports. We have extensive reports from South Sudan on the very tiny, I would say, and that is the tip of the iceberg of situations that we are seeing in the locations where we are operating. So this year we released a report on South Darfur, compilation, South Darfur, all Darfur's compilation of almost 2 years of medical data on sexual violence, and particularly concerned with Bashir fall, and it's systematic, it's constant, and it's here we go to the end of impunity. It's how to make those parties accountable. There is no one group that behaves better than the other one. We have not only women, we have men, we have children. So the extent and the use of sexual violence in many of the conflicts in this region is not a secret, and it's something that really needs to be continuously spoken. The role of local communities is crucial. The only way for us to be able to identify, to detect, to sensitize local communities on the importance, and we're talking about the stigma, we're talking about a lot of fear, we are talking about lack of access, communities, patients, victims that have no possibility to reach because potentially they might be perceived as part of or they are in one part of the front line or belonging to one community or having fear or stigma among their own communities. And the role of local actors, community-based organizations is crucial for us. So one of the first works that we do as soon as we start projects is to try to identify and map very quickly who are the people in the community to help us to early detect and to really help us to sensitize. The only way to really try to reach fast and provide the first aid kits and first aid assistance to victims is a strong partnership between the services that we provide and the engagement that we have with communities. So just a word of encouragement. I cannot help you with financing mechanisms, but as organization MSF, we are supporting, training, preparing, identifying all those local actors to help us to really quickly try to identify and provide service to those victims. So that's a crucial component for our programs. And I can explain later on. On the political actors and protection of medical mission, as you might have seen, we have been targeted. The resolution 2288 was due to an attack in Kunduz hospital in Afghanistan. So we have been constantly, and we meaning not only MSF, we are operating in hospitals that are under the Ministry of Health in many of the locations. So you will hear a lot of MSF attacks, but at the end, many of those locations are hospitals or facilities that are, or ambulances of medical staff, colleagues that are being affected. So I will say it's not only a call to the armed actors. In the case of East Africa, governments are the main perpetrator. So that's an element that is sticky, difficult, needs to be said, it's mentioned, but I really want to emphasize, and we have lost 3 colleagues in 2021 in Tigray war, most likely ENDF. We have been bombed in South Sudan, the only party with helicopters, we know who it is. So, and the point of drones, it's indeed a critical element. It's not only changing the warfare, but in the case of service provision, we are facing a massive challenge. Before, imagine frontlines, the traditional way of warfare, hospitals or health providers were prepared to certain type of war wounds. We were closer to the front line. The drones are posing a challenge to our teams because any health facility has to be ready to receive patients that they were not prepared. So we are responding in Tina, Chad, and we are receiving in attacks from Tina, Sudan. Teams are deploying Tina, Chad. Normal facility that is prepared to receive influx of refugees. So we are health facility and health providers and the colleagues are prepared to certain type of morbidities and to support people. Now we have to shift and change the type of programs because we are receiving burns, channel, trauma that we were not, or that facility was not prepared. So drones is changing completely the environment, and it's a very sticky conversation. It's a conversation that is taking place. It's part of my work. So I can reassure you that we are having very difficult conversations with authorities that are not always available, not always open, not always willing to have these conversations, because for them it's national security or it's different elements that are very hard to convey. So conversations are there, not going on the right way. Perhaps in Gaza, we don't have to go very far, but that part of the work of this year on the anniversary of the resolution is to really try to work on how to create mechanisms to really make states accountable that are one of the main violators of EHAGL. And on corruption, I just want to add that I think it's a key element, and I'm glad the report is addressing it, because impunity it has different shapes. We have seen how, and I always said it's not lack of resources. It's of South Sudan. Kenya it's beyond explanation, but in the case of South Sudan, no, in the sense that there is a country that has a lot of resources, has a system, has a structure. But in the case of South Sudan, there are resources, limited, but there are. And it's absolutely unacceptable that it doesn't go to the places that it should go. So I think the only is the message of empowering civil society and you as individuals and nationals of your countries, of our countries. I'm so glad to hear that we have learned some good things. But I think the only message is as youth, as individuals, as local community, local organizations, you have to really make accountable those authorities, because there is no other way. I don't have any other advice, but just wanted to give those words.
Thank you so much. I'm so sorry that our time is far spent, but I'm going to give you the last minute, if you don't mind, to address what you had in mind to address. Please go ahead.
Thank you. I really hope 1 minute will be enough. I didn't pick the name of the member in the audience who asked me a question, but I've seen your face and I'm happy to engage even during the cocktail we'll be having. Now I'm going to speak, I might speak with a bit of bias, because I'm a medical doctor who has worked as the intersection of health, peace, women's leadership, and name those things. I've worked for MSF too, and I feel very hurt when the facilities run by MSF are actually pumped. Now, when I say I've worked at the intersection of peace, I have actually participated in the negotiation of our current peace agreement as a youth representative, and I'm a signatory to it. Those political actors, when you ask whether they are being engaged, yes, not robustly, not realistically. Somebody else will give a different response. Partly because of what Monica has said, that the perpetrators, the culprits, in most cases, and in our context, particularly South Sudan, it's the government of the day. And so when those responsible for holding them accountable ordinarily should be, first, of course, the citizens who have their civic spaces stifled, so they are not unable to speak. And then we have the regional bodies who are signatory to the peace agreement, which stipulates a number of things. Chapter 2 talks about the importance of upholding the ceasefire. And when we talk about ceasefire, it's not just the arms, it's ensuring that that ceasefire enables us to achieve humanitarian goals, humanitarian health goals. But that is, they are not doing that. What happens is that whenever something like this happens, like when MSF-run facilities were bombed, there was no statement from EHAGL, there was no statement from the C5, there was only statements from the Troika, for example. And the Troika actually didn't sign the agreement this time round, but they're the only ones who spoke. Now, there's it's paradoxical that when it comes to this, again, we are talking localization, that accountability is also not localized when the government is the perpetrator. You have international actors are the ones calling out the perpetrator, but the governments which are close here are simply patting the other on the back and rubbing shoulders with them instead of telling them that what you did is wrong, you're killing people, you're destroying health facilities. And of course, the spillover is some people then come here for medical tourism to Kenya, or come for healthcare that they can't afford, and if they can't afford, some of them, of course, will die. And that's what we said in the commission report, that it's not just conflict that kills people. It's when a health system is weakened and destroyed that kills more people at the end of the day. So civil society too, in our case, and I'm going to say this deliberately, that our education system as medical doctors, how we are trained, we are not trained enough to speak out. In our context, again, when facilities were banned, you would have expected in Kenya, it's slightly different. Again, I'm saying this carefully because in Kenya, then you would have had the KMPDU speak up and all of that. In our context, that is not the case. But not just because of civic space, it's because of the training, that we are not trained to be healthcare workers who are also going to pursue this in some way. That's a conversation that is happening with other curriculums changing in other parts of the world. I think Australia is moving towards that. But here we are yet to move towards ensuring that the healthcare workers we churn out are able to work in those contexts, keeping in mind that they are also supposed to help in some way for this to be attained. Now, I want to go quickly. Please engage me after. The answer is lengthy. I have a lot of details, but I want to speak to corruption. I sit here and South Sudan is a culprit. I feel ashamed, but it's what it is. Now, what can be done about corruption? I'm just going to share an example of what has worked in our context that can be linked to health programs. We've had a girls' education program in South Sudan, initially started by FCU 10 years ago. And what they did is working to ensure that they strengthen PFM, public finance management, in our context, in relation to the delivery of the education program as it is. It worked so well that after about 3 years, then the other donors, Sweden, Norway, they pumped in money. It was no longer FCDO because it worked well. And we did see leakage of resources during that program. That is something that can be learned. So my answer would be to strengthen public finance management at all levels so that then corruption is fought when delivering humanitarian health, for example. Thank you.
A round of applause for these panelists. Thank you all so much. We haven't answered all your questions, but as Emily said, please let's engage with one another in the next room. We're in Woodville 1. In Woodville 2, we have a bit of a cocktail there. Would love to really speak to everyone that I've been bombarding with emails trying to get you to come, and thank you for coming. I'm eager to speak to every one of you. So please let's stay behind and just go right to the next room. Up here, you will see that this is not the only launch we're doing. This is the 4th so far. We still have 3 coming up. So, try to sign on if you can to see how this report is received in different contexts. Thank you all so much once again for coming. And I'm going to give this mic to Orit.
This one thing is that the commission does not end with the publishing of this report. We do have a post-commission agenda, and it includes things as engaging donors, engaging civil society, engaging regional bodies. You can see that work that's evolving. We're trying to create a global humanitarian protection alliance that addresses attacks on healthcare. We'll have regional observatories that are going to track indicators that help us understand whether we're moving forward on these recommendations, so they don't become reforms that are left behind in the future. So we can talk about that more as well.
Thank you, because that answers the question of what happens after the report. How do we make sure it goes beyond the report? Yeah. So there is a plan for a post-commission process. Thank you so much, everyone. See you in the next room.
What have you been working on?
Gender violence.
Always. How are you? Good to see you. Good to see you. How are you?
Very much. So when it comes to
Thank you all. We have the perfect panel. Thank you so much.
No,
Such a
pleasure.
wonderful speech. How are you? Thank you.
everybody.